Okay, I think it's live now. Woodman, can you just check on YouTube?
Notification is showing it's live now.
Okay, fine. Thank you so much, Rohit ji. Thank you.
Okay, sir. Okay.
So, good evening, everybody. I welcome you all to the 29th season of IRSI Online Video Symposium. When the going gets tough, the tough get going. It's an interactive video symposium on challenging cataract cases. And today we have world's some of the finest surgeons who loves to take challenge, and they have years of experience with them as our panelists. So I'd like to thank all of you for taking out time to discuss the case with the presenters. So firstly, I'd like to welcome Dr. Boris Malygin from Moscow, Russia. I think Dr. Malygin doesn't need any introduction. We all are indebted to Dr. Malygin for making our lives so easy and, extending our life by not less than 10 to 15 years by inventing Malygin ring, which has made our life very easy. Thank you so much, Dr. Malygin, for joining for this symposium. I'm joined by my co-host, Dr. Vardhman Kakaria. I'll request him to introduce next panelist.
Thank you, Harshul Bhai. It's always such a great pleasure to associate in this IRSI symposium. When the going gets tough, the tough gets going. And again, from my side also, I would like to extend the warm welcome to Professor Malygin. And we have amazing array of panelists today. I would like to now introduce Dr. Kumar. Dr. Kumar Doctor is a internationally renowned cataract and refractive surgeon in Mumbai. He is the medical director of the Dr. Eye Institute, and he's the first surgeon to perform the presbyopic classic inner pseudophakic eye in the world. And he always deals with a lot of complex cases, and he's also going to showcase one of his interesting case today. Welcome, Dr. Kumar.
Thank you.
Yeah. So next we have our panelist, Dr. Rohit Om Prakash. Can you just turn on your video, Dr. Rohit? Dr. Rohit Om Prakash is director of Om Prakash Eye Institute at Amritsar. We all know he's a prolific cataract and refractive surgeon, an innovator, has a lot of innovations to his name. And we all are looking forward always for Winter IRSI, which is a grand success. Welcome, Dr. Rohit Om Prakash, on this program.
Yeah. Thank you, Dr. Harshul. It's a privilege to be part of your beautiful symposium.
Next, we have our own Dr. KP, Dr. Krishna Prasad, who is quite loved across in India and also internationally. He's a great teacher, and his core interest is pediatric ophthalmology, refraction, and of course, advanced cataract surgery. And we are looking forward to his very practical pearls today. Welcome, Dr. KP.
Thank you, Harshul and Vardhaman. Thank you very much for the
Welcome, Dr. KP. And next we have Dr. Priya Narang. I think Dr. Priya Narang also needs no introduction. She's has taken Indian ophthalmology at the international platform, and she has a lot of innovations to her name and a lot of international awards, video awards and papers in peer-reviewed journals, JCRS and all different journals. And she's always a great teacher. I think Dr. Priya has contributed immensely to SFT, and recently she has come up with reverse single pass fourth row, which she recently won award for that technique. We welcome you, Dr. Priya, and looking forward for your immense contribution to this show.
Thank you so much, Dr. Harshul and Dr. Vardhaman, for having me here. It's always a pleasure. Thank you so much. So honored.
Next, we have Dr. Shikha Basi from Shankar Netralaya. She is a senior cataract surgeon as well as a neuro-ophthalmologist, so something with a dual, let's say, interest. She is a prolific refractive cataract surgeon and has been a senior consultant for a long time, has taught a lot of students in Shankar Netralaya. I've also had opportunity to learn from her when I was there during my tenure till to almost 2010. We are definitely looking forward to her amazing pearls today to learn from her as well. Welcome, Dr. SRB, Dr. Shikha. Yeah.
Okay. So I think before we start with the first presenter, I'll request Dr. Vardhaman to just brief us about the format of this symposia.
Yeah, thank you. So basically, friends, this is a very unique symposium. When the going gets tough, we all know that only the tough will get going. And as surgeons, we all have intraoperative situations which are unforeseen. And our surgical minds start working that time. Our surgical maneuvers, our surgical mindset, our surgical planning, basically all has to be fine-tuned for those special occasions. So the main purpose of putting up this new webinar is to showcase such intraoperative situations by our expert surgeons. And this is going to be a 5-minute video, which will be showcased by our expert surgeons, and the experts, our panelists, are going to stop this video time to time to tell their own inputs, to tell what could have been done in different way, to tell also and appreciate what has been done in the right way, and to add to the science. So there are going to be no didactic talks. This is going to be a pure interactive and full of learning experience for all of us.
Yeah, thank you so much, Vardhaman. So let's start with the first presenter. So the first presenter we have is today Dr. Ivan. Dr. Ivan is from Moscow, Russia. He is a postgraduate student at Fyodorov Eye Microsurgery Federal State Institution, Moscow, Russia. He is doing his post-graduation under Dr. Boris Meligan. So Dr. Ivan, with his first case, and I'll request Dr. Krishna Prasad and Dr. Shikhavasi to discuss this case with Ivan. They can stop the case anywhere they want, and they want to put in any points that what could have been done differently, because we all know there are many ways to skin the cat. So there is no one way. So let's hear from the panelists also what they feel about the case and how they would have done differently. Dr. Ivan, can you share your case?
Okay, thank you. Okay, 1 minute, 1 second. Okay. I would like to present to you a clinical case of refractive lancectomy and intraocular lens implantation with scleral fixation IOL using modified tension, capsule tension ring and Gore-Tex suture in a patient with the Marfan syndrome. Patient underwent a comprehensive ophthalmologic examination, and still lamp examination showed bilateral upward lens ectopia in the superior temporal direction. The target post-operative refraction was set at -3 spherical equivalent at the both eyes. Okay. Intraoperative OCT, they see the zonal fibers of the lens, then one tunnel corneal incision and 4 1mm incisions, Weiska surgical device, and we need capsulotomy by a 27 gauge needle and capsule rexis.
Dr. Ivan, if you can pause the video. So what kind of OVD did you use to put in anterior chamber at this stage, as soon as you started the case?
We used Alcon viscous surgical devices like Viscot. Yes, but in this case, we use another analog from Russian industries.
Okay.
Okay. So it's always good to use an OVD which has a dispersive OVD which can protect, the vitreous phase and before you start the case, right? So that's the idea.
Yes. And the next step is capsular rexis, and we need to capsule tension hooks and phaco aspiration. The next step is viscosurgical devices and more cortical. In this, I post in this video, we see in operative OCT, we see posterior capsule of lens. It's a good visualization. Next step is implantation. Next step is modified capsular tension reed. We implanted in capsule, and next step we prepare the conjunctive for scleral access to millimeters from the limbus. And we using Gore-Tex suture and fixation by Gore-Tex, using Gore-Tex CTR ring, and you see the using a 27 gauge needle, suture put inside needle and pass through the sclera. This one, and the same technique to this one. Then they need deepen of the sclera for knot and tight. Okay. Deepen on sclera, deep inside. And the next step is IOL implantation. And aspiration of viscosurgical devices. And in this screenshot, we see in OCT, we see lens, IOL, and in capsule, and in a good position. Yes, you see it. 1 month later, next another eye, the same steps of the operation, capsulotomy and capsulorhexis. The ectopia in the right eye was less in the left, so it was decided not to suture the lens to the sclera. Position for IOL, and 1 month post-op, we see this screenshot pictures from slit lamp, and we see that on right eye BCVA was 1.0, and left eye BCVA was 0.3. And because in the left eye, patient have amblyopia, and this eye this eye from childhood have okay.
Yeah.
Okay.
Okay.
Perfect.
Dr.
This-
Ivan, I think very well presented. I think congratulations for a very nice presentation. One word about what is the modification?
Can you stop screen sharing, Ivan?
Yeah.
Okay.
We would like to know what was the modification in the capsular tension ring that you were talking about?
This capsule tension ring modified by in our institute in Moscow. It's
Mulligan modified CTR.
huh?
It's a Mulligan modified CTR. Dr.
Yes,
Boris, I remember you won the
model.
award. You won the award for this ring in 2012 or 13 in ESCRS. Long
I
time
think
back.
Yeah, I think it was quite a long time ago. Yeah, the
Is it
modification
commercially available?
It is commercially available in Russia and in Europe as well. So they are. This is produced by Morcher and in Europe and in Russia by the Russian company. And back to KP question, the modification was in moving the fixation element to the tip of the device. So to make it injectable. So that was quite quite a simple modification, by the way, not very sophisticated, but it make it more, I should say, more useful to play with it during the surgery.
Yeah, I was just trying to tell the same thing. It's such a simple modification, but made the whole thing so different, because putting a Sioni ring has to be manually inserted, which actually you can miss the track. You can always have a problem trying to meddle that central or the double Sioni. So this is much easier. At the same time, a little concern about the vortex exteriorized when normally you make a small scleral pocket and try to push it. Is there any chances that that area may get infected, can create a track for the microbes to get into the eye or anything?
No, so we are not using the scleral flaps, but rather place and rotate the knot inside the sclera. For that, you have to enlarge a little bit the sclerotomy, one of the sclerotomies. And when the knot is inside the sclera, then there is no risk of exposure, because there were some publication about exposure of the knot, including the Gore-Tex knot, and definitely that we want to avoid. So if you rotate the knot inside the sclera, there is no need for scleral flap. Alternatively, you can use scleral flap, then you don't need to rotate. So whatever you prefer, without scleral flap, it's a little bit quicker. But
And was the idea behind not putting, fixing it the second eye you didn't fix it to the scleral wall, Ivan?
In the second case, we not fixed to the sclera because the ectopia in the second eye more or less than ectopia in the left eye, first eye. And you see that in this video we have good central position of IOL, and we did need more traumatic fixation in sclera. And
so
maybe
don't you think only CTR would have served the purpose if you don't want to fix it to the scleral wall?
It was intraoperative decision, yes.
I think they have only Dr. Mulligan's modified CTRs only in the operating room, I think.
Dr. Rohit Om Prakash wants to add something. Yes.
Yeah. I think it was excellently done. Because this is a panel discussion wherein we want to have different viewpoints about the same thing. In those cataracts where the nuclear sclerosis is not there, as it was not in this case, I would have used CTR and Sioni segment separately. I would have gone in with CTR early on, because I want to have, a big horizontal equatorial, done from all places, so that there is no aspiration of at times the equator. Number one. Number two, I would have liked to the way the CTR was implanted. I would have gone in such a way that it would have hit that part of the bag where the zonules were intact. Here, as you would have seen, it was putting more stress on the zonules when one was going in from that part of the bag which did not have zonules. So in those cases where there is a, zonular dehiscence is there, and if it is more than 90 degrees, one should always try to introduce the CTR in such a way that you go through the area where the zonules are intact first. So this is how I feel, I would like to have opinion of others also.
Okay.
Yeah, and I would, use a segment later on, because when you use this, you have to go in one go. And that could not have been done early on. Yeah.
Dr. Shikha, your
Yeah,
views?
as you've already pointed out, Dr. Harshul, my query to Dr. Malyogan was why not use a plain CTR if you're not planning to support it with scleral fixation. But I just want to know, there's any possibility of damage by the extra attachment that the CTR has. If we are using, it seems like a bulky thing compared to the normal CTR. If a person does not have that much of expertise, though we've got an injectable system to put the CTR inside, putting a simple CTR in this kind of subluxation, it wasn't that great, as Ivan said. We could have used a simple CTR. Second thing, as Dr. Rohit said, that supporting the unsupported area while injecting is important. The hooks were removed before putting the CTR, modified CTR. So probably the hooks, support, capsular support could have been retained and while injecting the CTR, but beautifully done surgeries and beautiful outcomes and a great invention. Definitely. I come from an institute where the cataract surgeons are hugely supported by the VR surgeons, and most of these, very, very subluxated cataracts are then the lens is completely taken out, and we put scleral fixated, which is another completely an SFIOL is done in these. That's another way it could have been done.
Yeah.
But great surgeons.
I have one more question, that in cases of progressive zonulopathy, we always tend to fix up the area which was already subluxated. But what happens to the remaining zonules over a period of time? Because having a follow-up of 6 months or 1 year doesn't suffice the need. So probably, I think it was very well handled, but would there be a possibility of considering and putting up another ring along with the cortex suture to support the other end also? Because over a period of time, maybe even that goes off. So, and the patient is a young patient, so has a long way to go. So maybe would that be a consideration when taking these cases?
I think it's a good question, and obviously the CTR is inside, and we can suture it anytime at any time point when we consider it necessary. So if it's not a pseudoexfoliative syndrome, that's why, and there is patient having no glaucoma, and although she is having myopia, which is sometimes associated with zonular weakness, as we know, and may lead to progressive zonular weakness. So I think we can come back anytime and suture the CTR to the sclera, and that was our point of not doing that on the second eye, as we've seen that it was possible to center the lens without suturing, and so we decided not to complicate the surgery by suturing, which may produce bleeding and some other issues. So I think we should keep our surgical technique as minimal as possible, but sufficient to do the case. And I think sometimes, of course, we had all these sutures at hand, and we can do that, but we decided, why should we do that at that point? It may not be needed at all in the future, but if so, we can come back and do that.
At this point,
Okay.
Dr. Malyogan, just wanted to know how often you've had the need to, take them up again. Like you would have done a lot of Marfans. So if you put this ring, how often you've had to put a second suture?
I had when I started to do this surgery, I used polypropylene sutures, and then that's why because of the suture lysis that happened about 6 or 7 years after the surgery, I have a number of cases where I need to revisit the case and change the suture. And that's why in my latest cases, I switched to Gore-Tex. And that's answering your questions, sometimes you need it, but this was because of improper suture material that we used in the first cases, and I will not recommend using 9 or 10 or polypropylene, which is a bit different with 5 or 6 polypropylene that might be used as a flange technique, and it's more stiff and thicker. And as far as I know, there are no cases of dislocation or lysis of that suture, at least so far. Although we did some electronic microscopy study of the polypropylene sutures, and we've seen a lot of cracks on the outer surface of the suture. So I think even 5-0 might biodegrade to some degree, hopefully not to the degree when it will lose the stiffness and strength because of it's thicker. But there will be some biodegradations for sure, because this is material that biodegrade.
Okay, I think let's move on to the next case, because this can be endless debate here. Thank you so much, Ivan, for showing this wonderful case. And Dr. Boris, we are looking forward for the modified CTR ring soon in India.
Yes.
So I think before
Okay.
we go to the presenter, I would like to just bring to our notice that we have been joined by our expert panelist, Dr. Jagatram Sir, Professor Jagatram Sir, who has been the ex-chief of the PGI, Postgraduate Institute and the Advanced Eye Center in Chandigarh. And Sir has been one of the pioneers of the pediatric cataract surgeries globally, and has probably one of the most prolific experiences that we have from as an Indian counterpart. So welcome, Dr. Jagatram Sir.
Okay, thank you so much.
Welcome, sir.
I was stuck up.
Yeah.
Yes.
So I think the next presentation is going to be by Dr. Prakash Kumar Chaudhary. So he's the academic director at the Chitrogram Lions Eye Institute and Hospital, and he's currently the vice president of the Bangladesh Society of Cataract and Refractive Surgery. He's also the executive director of the Bangladesh Eye Hospital at Chitrogram. And he is a very prolific cataract and refractive surgeon, and he's going to showcase his interesting case to us now. Over to you, Dr. Prakash Chaudhary. Thank you.
And I'll request Dr. Kumar and Dr. Boris to discuss this case. Dr. Kumar, you're there?
Yes, I'm there.
Okay. Dr. Prakash, I'll be sharing my screen.
Okay, you can play.
Okay. So just let me know when you want me to pause.
That screen is Jalana.
Yes. Okay. So here is his case.
There's no
The
audio.
audio is not coming.
There's no audio.
Yeah, there's no audio at all.
So,
No audio?
so
Wait,
can I
wait,
start
wait.
from?
You want to narrate this or?
Okay, if no
Wait.
audio is there, I can do that. You just run the video, but sometimes the internet is not.
No, I'll just. Sorry, I didn't know there is a sound need to be shared. I'm just sharing again. Don't worry, it will come. Just check once now.
Till that time, we will just welcome also our panelist, Dr. Gaurav Luthra from Dehradun. He is the ARC chairperson of the IRSI, and he has been the past scientific committee member of AIOS and a senior cataract and refractive surgeon from British Institute. And also from Dr. Deepak Magur from Bidar. He is a very prolific teacher in cataract surgery. He has one of the biggest YouTube channels to teach youngsters. Welcome.
Okay.
Thanks, Vardhaman, and good evening, everybody.
Welcome, Dr. Gaurav. Welcome,
Thanks,
Dr.
Harshal.
Deepak.
Thank you so much. Sorry for being late.
Okay, let me play it again.
At the outset, I would like to convey my heartfelt thanks.
Can you hear the sound now?
Yes, yes.
Okay.
To Dr. Harshal to give me the opportunity to use this platform, and thanks to everyone and respected panelists. In next few minutes, I will share my unwanted experience while I was dealing with a normal cataracts. I was a 50 years old man having soft cataract with limbal dermoid, and there is no history of any ocular trauma and no significant astigmatism besides limbal dermoid. The K1 was 42.5 diopter and K2 was 43.05 diopter. The other eye was quite normal, and the patient was planned for phaco with trifocal IOL under topical anesthesia. After making the 2.4 millimeter main port, now I am creating an optimum size axis using 26 gauge band needle cystotome. Now I am doing hydrodissection with a Akahosi, a small band hydrocannula, and inject fluid.
So, Dr. Prakash, you're muted right now.
Yeah.
Okay. So what happened just now? Can you just?
Now, it was actually preoperatively, I was missed that there is subluxations in the subincisional area. But after making the axis that I did the hydrodissections with a small band Akausi hydrocannula. And after being that, I noticed there is a subluxations in the subincisional area.
Okay, okay.
I think
so let's move ahead. Yeah.
Because of the dermoid, I think the visualization must be poor. Subincisional to probably understand this.
We will see it later on.
Yeah.
Behind the equator, and immediately I decompress the nucleus. At this point, I noticed there is subluxation at subincisional area, which I missed during preoperative examination. Now I proceed for scouting very cautiously with very low parameters to avoid any undue pressure in the capsular bag and to take care of weak zonules. Here my bottle height is only 50 centimeter, and I have also corresponding low aspiration flow rate, only 18 cc per minute, and low BICOM, only 18 millimeter mercury. My preferred technique for soft cataract is 4-quadrant nucleotomy. Here, to avoid stress on zonules, I planned for chip and flip technique to deal with the nucleus. And before take out the phaco probe from the eye, I am injecting OVD through the side port. My next plan is to introduce CTA ring to stabilize the capsular bag. And to do that, here I am injecting cohesive OVD under the capsule to create a space. After being that, successfully I put the CTA ring into the capsular bag. Now to confirm the presence of bitters, I inject diluted triamcinolone acetonide into the anterior chamber. Here I am swiping the main port with a spatula through the side port. After being that, educate vitrectomy was done with high card rate but low bottle height and low aspiration flow rate and low BICOM. Again, I inject dispersive OVD through the side port before take out the irrigation handpiece from the eye. Again, I am swiping the main port with the spatula, and here I am doing dry vitrectomy with high card rate. Now I am swiping the side port from the main port with a spatula and cut the bitters with the cutter. After being that, I remove remaining nucleus with the phaco probe with low bottle height and corresponding low aspiration flow rate and appropriate beacon. Now it's time for cortex removal, but pupil size get down. Here I am injecting cohesive OBD under the iris to lift up the iris. Now to expand the pupil size, here I am using 4 iris hook. Now I proceed to remove the cortex with bimanual IA with low bottle height only 50 cm. It was very difficult to remove the cortex as the cortex are stuck with the CTR ring. So by moving the aspiration port tangentially, I am separating the lens cortex from the capsular bag and all cortex are being removed. Now it's time to implant the IOL. Here we can see the rexus margins is circular. I decided to implant the unifocal IOL. But because of patient's demand, I proceed to implant multifocal oil under cohesive OBD. Again, I inject diluted triamcinolone acetonide to see the presence of vitreous and swab the main port with a spatula. Adequate vitrectomy again performed with high cut rate, with low bottle height, low aspiration flow rate, and appropriate beacon. The 4 hooks are removed, and I took a bite in the main port. Then remaining OBD is being removed with bimanual IA with low bottle height. I inject pilocarpine to constrict the pupil. And at last, side ports are hydrated and case is over. It was fast post-operative day. Only a slightly edematous. Patient is happy. Thank you so much.
Thank you so much, Dr. Prakash, for sharing this case. And now I'll request Dr. Boris and Dr. Kumar with their
I think the
opinion.
Interesting point was the discovery of the zonular lysis during the surgery, which was not really expected at the beginning. And obviously, it was a good idea to utilize capsular tension ring to restore the equator of the capsule bag. However, as we seen from that video, and I think it's a very interesting take-home message, so even if you implant CTR, you do not restore the zonules, and there is still a chance for the vitreous to go around the equator and enter the anterior chamber. So probably the combination of the CTR with the hooks will be the best option in that case. However, in my experience, sometimes even if you combine the hooks with the CTR, still because there is a gaps in between the hooks, so it's still a possibility for the vitreous to come out. I think using triamcinolone was a great idea to visualize the vitreous, and there is a controversy which approach to use to remove that vitreous. Some surgeons like to do it from the anterior approach. The others prefer sclerotomy and to use the posterior approach. And this is, again, a matter of debates, what is better. But I think it was done very elegantly and easy from the anterior axis, and that was good. And my question to Dr. Prakash, if you have a mixture of viscoelastic and vitreous and triamcinolone in anterior chamber, do you adjust your settings of your vitrectomy probe, like fluidics? So tell us a little bit about your settings of vitrectomy to effectively remove that vitreous without any complications.
Yes, thank you so much, Dr. Boris. And my preferred techniques, I use actually dispersive OBD to tamponate the vitreous. And during vitrectomy, I use maximum cut rate. Here I use 4,000s. And always I keep my infusion flow rate is low. I use only, I think, 50 centimeter. And corresponding, I have also low aspiration flow rate only 20 cc and moderate vacuum, 250 or 300 millimeter mercury. And that's my usually I follow during vicectomy.
Okay, finally, so you decided to implant single piece multifocal lens, which I don't think everybody will do that. At least I think I will probably hesitate a little bit about the implantation of the multifocal lens, although astigmatism was quite low in spite of the big dermoid, which I'm a bit surprised. 0.5 of astigmatism in such a big dermoid seems to be a very lucky thing. So there is a possibility for the good vision, although I'm a little bit concerned about the stability of the implant later on. So I will probably, my personal preference will be to consider monofocal lens in that case, and I will be happy with that. And I think the patient will do that.
Dr. Kumar?
Yes, I request the patients as to I would like to go with the monofocal IOL. At the OT table, I decided to go for monofocal IOL because I was worried about the astigmatism, post-operative astigmatisms. But luckily, the day before yesterday, I have seen the patient. There is at least no astigmatism over there, but it was there. But patient is determined that he will go with the trifocal IOL. And I also convey the message because if the lens is decentered, there is a capsular support is not well. So there is a possibility of the decentrations or image distortions, and the contrast sensitivity may be poor. Even all these things in the OT table, even in the OT table, he called me that yes, call my wife. I would like to discuss with my wife. And I call his wife also, and his wife also say yes. If it is not appropriate or I cannot enjoy the good visions, later on, can I remove it? Yes, I can. You can remove it. Okay, go with the trifocal. Then I implant trifocal IOL. But I was lucky that post-operative the patient is enjoying good visions.
So what Dr. Prakash has done is he has put all the blame on wife now. Now, even if decenters, its blame is on wife, Dr. Prakash, because she consented. Okay, Dr. Kumar.
So very nice, Dr. Prakash, very impressive. Only thing what I do when we have such a large dermoid, I would like to do a UBM pre-operatively because I would like to know the depth of this dermoid. You may be surprised, sometimes you can catch this zonular dehiscence by the UBM initially only. And one more thing different I would do is once you realize that you had a zonular dehiscence, what I would do is I would put a capsular hook posterior to your incision, and then analyze how much is the dehiscence. So you had almost 4 o'clock hours of dehiscence. Then I would stop my surgery, put capsular hooks posterior to the incision, and one more capsular hook lateral, and that will support my bag, and then gone ahead and done the phaco. It was perfectly correct that you put the viscoelastic below the anterior capsule, created your space, and then put the endocapsular ring. That's the right way to do because that prevents the entrapment of the cortex. So that was very well done. But ultimately, again, to use the 4 hooks and to get the cortex out was also a good trick. I mean, that just tells doctors that don't get lazy, don't be overconfident, make sure that you're holding the right thing and getting it out. As far as the single piece multifocal IOL is concerned, I might have selected a 3-piece multifocal IOL, but I understand that sometimes we are telling a patient for a trifocal IOL, but if you have an access to a multifocal, which is a 3-piece multifocal IOL, which is there nowadays available, then I might have selected a 3-piece multifocal IOL with the haptics in the direction of the area of the subluxation. So you have your endocapsular ring and you have your haptics supporting the area of the subluxation. But what Boris said was perfect about the vitrectomy. Anyone would have, yes, that's the right approach, and that would have taken care of that in the future. Excellent case, Dr. Prakash.
Thank you so much, Dr. Prakash, for showing this wonderful case. I think let's move on to the next presenter. Okay. So next presenter we have Dr. Vanashi Nair, and Dr. Vanashi is a consultant cataract and refractive surgeon at Girdhar Eye Institute, Cochin. He has done MS from Grant Medical College, Mumbai, and long-term fellowship in phaco-refractive surgery from Asian Eye Institute, Mumbai. And she has completed FICO exam and FRCS Glasgow in 2020. And she's a prolific cataract and refractive surgeon, as well as a very good singer. Dr. Vanashi Nair with her case.
Thank you, sir.
So-
Thank you for the opportunity, first of all, to give me the opportunity to present in this symposium. So would you be sharing the video or should I?
Yes. Whatever you want me to share. Okay. Let me know when you want me to pause the video for you.
Right, sir.
I'll be sharing.
So this is a case of a 73-year-old female. So can you pause for a second? So this was a female, 73 years old female with a grade 2 nuclear sclerosis. And
Just a minute,
yeah.
Just a minute, Dr. Vanashi. I'll
Yeah.
request Dr. Gaurav Luthra and Dr. Priya Narang to discuss this case with Dr. Vanashi.
Sure, sure. Thanks.
Yeah.
Right, sir. So this was a 73-year-old female with the grade 2 nuclear sclerosis and inferior cortical cataract, as you can see, and it was the plan for a toric IOL implantation. So can you play the video? So I started with my capsular axis, and as I was reaching in the sub-incisional area, you can see that the needle actually disconnected from the syringe, and it just fell down. And in my attempt to reattach it, I thought I'll allow the cystotome to remain inside, but somehow, to my bad luck, it got dragged out. So I decided to make my main port and go through the main port and check on the rhexis. So as I was just nudging onto the flap, I realized that it had already gone under the rhexis the pupil margin. So I went with the Krugland-Suk to check whether how much it had extended to the periphery, but because of the cortex, the visualization became difficult there. So
I think there are some issues with the internet connectivity.
it was a glitch.
Yeah. Okay.
Oh, yeah,
Are you
yeah.
there?
Sorry, I'm back. Okay, can you hear me?
Okay.
Yeah, I'm here. There was a power failure
Okay.
over here. Can you hear me?
Yes.
Yeah. Can
I'm
you please
playing
play?
it. Yeah.
Yeah. I cannot see the play. Yeah. So I went with the microrhexis forceps, and to get a better visualization, I took a Krugland-Suk from that side and tried to use the little maneuver and try to pull it in, but somehow I thought that I'm not getting a visualization there. And I nudged it a little, but then I stopped. I was like, this is not the way to go ahead, and I'm just going to create more damage perhaps. I again tried to visualize till what extent it had gone, but I had a poor view. So the next step was to go and take a nick from the other side and try to complete some amount of capsular rhexis so that I have a circular opening, and I managed to complete the flap on this side. Then I went ahead and gently put some amount of fluid to have some hydrodissection and decompressed in between so that there's not much pressure in the area where the rhexis had extended. Gently, I didn't want to rotate the nucleus completely. I gently tapped on it, and I started with my phacoemulsification. I wanted to go with stop and chop, slowly pressing the nucleus down and then rotating it so that there's no pressure in that area. And I went ahead. Is the video playing well over there? Because I can see it a little stuck over here. Is the video playing?
No, it's playing well here because.
Okay, fine.
Yeah.
Fine. So then I had two pieces, and I took each of the nucleus, and because there was a rhexis extension, the piece came up into the AC, and I injected some more viscoelastic and took the second piece. And when I reached the end of the phacoemulsification, was trying to be a little slow so that I had the piece into the probe. And before coming out, it is important that we maintain the anterior chamber with viscoelastic and then take the main probe out. So here I went and checked again to see what was the level of damage to the rhexis margin. Then I went ahead with the bimanual technique of cortex aspiration. So my preferred technique is to go away from the area of rexus extension. And before you exchange the hands, again, it is important that to maintain the anterior chamber, we inject some viscoelastic and then change over the hands. On the side where the rexus had extended, I decided to be slow and gentle and pull out the cortex in all the areas other than the place where the rexus had extended. And to my good luck, I could manage to take out the cortex well. And the last bit of the cortex came off, and the bag was intact.
Okay. So can we just take a pause here? And
yeah.
I'd like to add Dr. Gaurav and Dr. Priya here. So what should be the plan of action now? How much was the astigmatism in this case?
So it was around 1.5. I was needing a T3 IOL. Actually, it was a plan for an Alcon toric IOL. So it was a plus 24 diopters, 180.
Okay.
So the markings are already present at 0-180 is what I had marked.
Dr. Gaurav?
Yeah, so Harshul, actually, Vanashri was, she's managed it so well. She's been able to complete the cataract surgery, all the cortex is gone. And thankfully, the bag, I can see most of the rexus rim is intact except in that small area. So I do feel that we can have, and fortunately, the implantation axis is exactly at 90 degrees to where the rexus is broken. So at the end of this process, if there is only a small break in the rexus and everything else is well managed, and we can put viscoelastic and deepen the chair, form the bag and see if everything looks good, I would go with the toric IOL at that one, at this axis as well. And also because it's a small toric axis, if there was a problem with the rexus and I was concerned about the bag not being able to retain a single piece lens, I might have even gone with a non-toric lens if there was a suspicion that I will not be able to, because with a small toric, this thing, you don't necessarily have to actually go with the toricity as well. So both options are actually open to us. So that decision has to be taken by the surgeon based on how confident the surgeon is that they will be able to get the lens into the bag. And the axis, of course, is very important. Had the same axis been at 90 degrees to this, I would have definitely not wanted to put a toric lens, because then my haptic would be coming straight at the point where the rexus was broken.
Yeah, even I feel Dr. Vanashri, she has managed it so well. There was no single point where I felt I would have done it differently. Probably have followed the same points. So, and I think, absolutely, I think she can go ahead with the toric, taking into consideration the axis that's there. The capsular rexus seems to be intact in that area. So I don't foresee any reason for not doing that.
Okay.
Right, so can you
and I think it's the message which everybody should get is how important it is to maintain closed chamber. So every time she was coming out, she was maintaining the chamber, which is very crucial, because otherwise you may have a wraparound tear. So.
And the other thing is that she managed that area. The wash was done last, so that's a very good thing, because you are clear with the entire cortical area. In case if you have some issues in that area, probably that area is the last area to handle, and maybe you can localize the defect if it was there. But I think she did everything perfect.
And one more message is that whenever you have a case like this where visibility is poor, as we saw in the inferior area where the cortical there was a cortical cataract, I think it's always better to stay in these kind of capsules so that you don't lose in those areas.
Visibility is often an issue in these cases.
Right. So I had actually stained it, but still I didn't have a well-stained capsule. If you notice the CCC when I was doing it, it was bluish. I had stained it, but probably didn't take up the stain that well. So as Luthra sir said, because the axis was at 0-180, I thought that I can try and implant the same lens as planned. So I injected the viscoelastic, took out my probe, again checked the axis with the dial, and slowly injected the IOL into the bag. So the leading haptic went into the bag, and then the trailing haptic I dialed into the bag, and with the other hand, I slowly tried to nudge it into place so that it is at 0-180, just short of 0-180, so that when I wash the viscoelastic, probably I'll just place it there. So now when I started removing the viscoelastic, if you can notice, I have a very strong two lines going straight across where the rexus had extended. Till now, I was oblivious. I thought this is maybe probably just the. So can you pause it here? So I hydrated the wounds, and at this point, I was thinking, has the rexus gone around? Is it a wraparound tear, or is it just a fold in the bag? I wasn't really sure, because those are really two strong lines which I could see, and even tapping the bag was not really helping. So I went and I put triamcinolone to check, but there was no vitreous disturbance. There was nothing. So can you pause it? What happened is, can you just pause it here? Yeah. So on day 5, I could see that line over there. Yeah, this was day 5. The patient was seeing 6/9 on day 5, and even after a month, you can see that it has just fibrosed a little more. And this is the picture almost a month later. Patient was 6/6 parts, and she took plus 0.5 at 180 diopters, and she was 6/6 with that. She was unhappy, unaided, but I was like, for quite some time, wondering whether it was just the folds in the capsular bag, or did I really have an extension. But looking at what has happened after almost a month, I think it was just folds in the bag that came because of the haptics. I would like comments from the experts if you had previous experiences like this.
Okay.
Can I make a comment?
Thank you so much.
Right, sir.
Harshul, can I make a comment?
Yes, Dr. Kumar.
So I'm a little confused. Is Vanishri a better surgeon or a better singer? So very well presented, Vanishri. It's very good. But one thing I would have never done is rotated this IOL. When you knew that there was a tear in that area, what I would have done is you already had the axis. Okay, I would have just nudged it into the place. Your haptics were in the right position, that your trailing haptic was in the right position, your leading haptic was in the right position, and it would have just sat. So I would have just nudged it into the bag and never rotate these IOLs when you have a confusion whenever you have this tear going around. So that's the only thing I would have never done or attempted, and that led to all this confusion. But ultimately, the patient's happy, you are happy, so the story is over.
Dr. Meligan?
It's a good learning point for me.
We can't hear you, Dr.
wants to say something.
I think Dr. Shital wanna comment. Yes, please.
Am I audible?
Yeah, Shital.
Yes.
Okay, I just wanted to make one comment. Very nice case, very well handled, Vanashri. But I think that was just a clear-cut tear in the PC, because when you had that zoomed up photo later on, you can see those fibrous margins. If it will not fibrose or become like this just with the folds. Second thing, I think you did not have any other problem, because maybe the anterior vitreous phase is very good, so you did not have any vitreous loss. So that was a good point. And nothing else also will happen in the future, but just like what I thought about it.
Yeah, I think I agree with Dr. Shital, because when we see the post-op slit lamp pictures, it looks like it was a rupture, and it was lucky to have it rotated and not rupturing the anterior hyaloid membrane. So it was a lot of luck in that case, I should say.
Yeah. So that also proves the point and importance of maintaining closed chamber, that vitreous phase didn't get disturbed. That only the rotation might have caused in the end, whatever. Okay.
Dr. Harshul, can I comment?
So, yes, sir.
I think this was so well managed case that she completed the rexis and removed the nucleus as well as the cortex very carefully, and implanted the toric IOL in the capsular bag and in the perfect axis. Regarding that fold, to me, initially, it appeared to be just a fold on the posterior capsule, but while seeing at 1 month, it appeared to be fibrosed. It means that maybe it was a linear type of tear. I am not sure, but it appeared like that. But it was so perfectly managed. This was just excellent, I can say.
Thank you so much, sir.
Okay. Vardman, yes.
Perfect. So I think, so now we'll go to the next case. We have the next presenter with us, who is from our own Maharashtra, Dr. Atul Kadane. Dr. Atul Kadane is currently practicing in Vidarbha. He is currently the Joint Secretary of the Maharashtra Ophthalmological Society. And I have pleasure of working along with him this and next year too. He has been the zonal member of MOS in the past, and he is currently the Secretary of the Vidarbha Ophthalmological Society. He's a very well-known cataract and artery segment surgeon in Vidarbha, and we are very excited to see his complex case scenario. Over to you, Dr. Kadane.
Yeah. And I'll request Dr. Jagatram sir and Dr. Deepak to discuss this case with Dr. Atul. Yeah.
Thank you
Yes,
very
Dr.
much.
Atul.
Yeah, at the outset, I would like to thank IRSI, Dr. Harshul Vardhaman, for giving me this opportunity. And I feel lucky that I'm sharing space with Dr. Boris, an international stalwart, and I'm lucky all the national stalwarts like Dr. Jagatram sir, Dr. Deepak sir, and everybody here. My case is a case. I will share a screen from my side, sir.
You want me to share? I will share for you.
I will share. Okay.
Okay. Perfect.
Where is the... Is it visible now, the screen?
Yeah.
Yes.
The audio is there in the clip, so I would like to just you tell me when I
Hello everyone. As you can see, this is a case of a traumatic subluxated cataract, almost 180 degree. I am marking the area of subluxation with the center of the subluxation. Managing a case of subluxated cataract is a surgical challenge. In this video, I'm going to demonstrate the use of IRSI anchor, a novel device to manage such type of cataracts. A cataract having subluxation more than 180 degree. The most critical step is to have a perfect CCC, irrespective of whichever method you use to fix the bag. Before CCC, just ensure that there is no vitreous in the anterior chamber. After a clear corneal incision of 2.65 or 2.8 millimeter, you can see that I'm inserting a tenoprolene needle 1.5 millimeter away from the center of a subluxation through sclera and bring it out through the main incision with the help of a cannula. Routinely, surgeons use Sionis ring to manage such type of cataract, but here in this case, I have used an implant called IRSI anchor. IRSI anchor is a 2.5 millimeter wide PMMA uniplanar implant. Now, once the tenoprolene needle is out, I am threading it through the central hole in the central rod of the implant. And after this, the tenoprolene needle is again taken back through the sclera at the same site with the help of a 26 number needle. The implant had two lateral arms which are positioned behind the anterior lens capsule, and the central element or the central rod is placed in front of an anterior capsule. Thus, it creates a clip that adheres to a small segment of the anterior capsules. Beside that, the tip of the lateral arms are designed to reach the lens equator and that provides segmental equatorial support, while the anterior rod is sutured to the scleral wall using a non-absorbable suture. Here you can see that the tenoprolene needle is now threaded back into the hub of a 26 number needle. So the implant provides two types of support, anterior capsular support as well as equatorial support. The uniplanar design of the implant facilitates the easy and the smooth insertion through a tight corneal incision. No need to enlarge the incision. However, the surgical skill which is required is the placement of the two lateral arms behind the capsule and the central element in front, as it's a uniplanar implant. So we can take, it requires some sort of intraocular manipulations, creating a space and then managing the lateral arms behind and the central rod in front with the help of a 25 gauge forceps, side port forceps. Now, once this is done, the temporary stay knot is tied and the implant is fixed in the position. After this, phacoemulsification procedure is just like a routine, as if we are doing day in and day out. The removal of cataract is a routine one, as if we are doing on a stable and a well-centered lens. This is the biggest advantage of IRSI anchor over the other methods because inserting a Sionis ring before removal of an cataract is not easy. You may shear out the rest of the zonules while passing the ring through that unstable bag through the entire circumference of the equator and create more damage. So while here the bag is fixed before removal, so doing a cataract procedure is easy, which is not an easy when you use other method to fix the bag. As there, you have to remove the cataract first. Now the implant is, now the knot is tied, final suture knot is tied with 4:3:1 fashion. And the knot is buried in the scleral tissue under the conjunctiva. No flaps are required. Dr. Iirsi had recommended no flaps to bury the knot, who is the inventor of this implant. Removal of an cortex is a routine procedure, as well as the placement of an intraocular lens in the bag. Once the lens goes in the bag, the remaining the suture knot the sutures are cut flush to the knot, and the remaining threads of the sutures are cut flush to the knot. And after removal of an viscoelastic and sealing of the side port incisions, the case is over. So we can see that IC anchor facilitates a creation of an centered IOL capsular bag complex, and therefore helps in an effective visual restoration. Thank you very much.
Yeah, wonderful case, Dr. Atul. It was certainly a challenging case. And so over to Dr. Jagatram sir for sir's expert opinion on this.
Yeah, I think Dr. Atul has done excellent job, because he has stabilized the capsular bag well with this AC anchor, and he has done that before even removal of the nucleus and cortex, and ultimately he has achieved well-centered IOL in the capsular bag. I think he has done outstanding job. I can say that. Whether I don't have the comparison whether this is as good as Sioni ring, but this appeared to be much better and much safer also, because it provides a very good hold to the capsular axis centration. So it is just excellent.
Sir, what about
Dr. Deepak?
Yeah,
Dr. I think Dr. Atul is an expert in this ASIA anchor. In India, majority of us still don't use this, and he's one of the few surgeons who has mastered the skill. It's very elegant, that because it's just design is so small and sleek, and and he managed to place it before. Conventionally, what we do, we support the bag with capsule hooks, finish the job, and then support it to a segment. But his technique, it's different. He introduced the clip beforehand itself, and looks very elegant. I don't have any personal experience with it, but I just like to have his opinion, like, how does he compare this with a conventional CT segment which we use now traditionally? Now, what do you feel is the advantage for us to switch over to this way? And also, I'm a little bit, intrigued by your the suture. You didn't use any scleral flap. It was left open, and I'd like to know what is the suture also you used. So please share me these 2 points now.
Actually, sir, I too feel that I should have made a Hoffman pocket to bury the knots. That was my mistake in that case. In the another, I have done up till now 6 assay anchor cases. This was my 3rd case, and after that, I started making a Hoffman pocket. And after hearing Dr. Boris about the degradation of the Prolin sutures in the first case, he said, I get a little bit of heartbreak, because my first case was in 2017. So it's now almost 6 years. And I'm in the regular follow-up of all these patients. Up till now, with God grace, nothing. No, the sutures are still there. Regarding the advantage,
what suture you used? What suture did you use here?
It's a Prolin sutures, 10O Prolin.
What gauge? 9O?
10O.
So that main concern is the biodegradation of the 10O Prolin over a period of time. It can go off quite. That was the concern for which.
The next case, I will try with the Gore-Tex suture. I'm thinking the next time. And the advantage I feel, sir, because I have done the case with CTS segments also with this thing. I feel it's much easier, because in those cases we have to first fix the bag with the help of capsular hooks. So one more step, And after that, then see, doing an phaco in an unstable bag, though we are fix it with the capsular hooks, and doing an phaco in a bag which is fixed with the AC anchor, which is a temporary stay knot we are already tied. So it's much more comfortable to the surgeon, I think. See, most of the times the cataract density is very less, so it's easily manageable. But if the cataract is grade 3 or 4, then in those cases, doing a phaco with a AC anchor in place is easier rather than doing a phaco with capsular hooks in place, because you may damage the PC and all those complications. That's what I will.
One more
Dr.
point.
Atul. Yeah.
Please go ahead. Good.
Yeah, Deepak, please.
The AC anchor, the span it's quite small, and
Yeah.
your span of zonal adhesions was quite huge. Okay.
Yeah, I support with the
almost 5 clock hours was your zonal adhesions, but the AC anchor, before you anchor it to the sclera, the span is quite small actually. But still, when you're doing surgery, it was looking very stable. Is there any role for introducing a CTR as well along with the the bag which is stabilized to the sclera? Is there a role for CTR as well in this?
That is another advantage I want to say. See, we have two supports. We have an anterior capsular support from these AC anchor, and you can put an CTR. I used to put CTR in all those cases after removal of the nucleus and the cortex. I put a CTR before putting an IOL implant. Though in this case, in the case which I showed, is I didn't put an CTR. It was in one of my beginning case, I think second or third case. But in the rest of the case, I use because you have an additional equatorial support from the CTR, and that is another advantage. You can have a support on both sides. Anterior capsular supports, those they said that the two lateral arms, the ends of the two lateral arms, they are supposed to touch to the equator. The central rod in front of the CCC and the two rods, the two below the CCC, those two gives a little bit of equatorial support also, but that is not that much of use. But the more often the CTR use is always good with the is always helpful, and I will advocate also that one should use an CTR also. That will put an additional protection.
I think this is excellent observation that CTR will give a much better support. Although this is the ultimate is this anchor, but CTR will give a better support for this because the subluxation is a quite a 180 degree, you said. But I think that may help in most of the cases.
And one more advantage, sir, I had used two AC anchor in one case. When I feel that it is not giving a sufficient support from one side, the bag is still not supported well, you can put another implant. It hardly requires only 1 o'clock hour of the bag. You can put it. The another advantage, it can be used in a subluxated IOL also. Means there are some cases in pseudo exfoliations when the whole capsular IOL capsular bag complex was wobbling like that. So in that, when you have to fix such a bag, to create a space for putting in CTR or putting in CONE or anything is not that easy. But for this AC anchor, you need to create a space only for 1 o'clock hour. You put a AC anchor and stabilize the bag. That is also, there is a very, very nice video about fixing such cases also.
So do you always introduce this AC anchors before you start your phaco after Rexis?
Yes, it is always before.
Always before that.
Always before. Only thing you have to create a space to see. Initially, they comes with the uniplanar. Now the difficulty, though it looks that easy because it's a very much edited video, it was not that easy to put that 2 prongs below it and 1 prong above. Now they come with a slightly deeper. There is a difference of plane, so that the facilitation of the AC anchor will be easy. Uniplanar advantage that it goes through the main incision smoothly, but putting it at the CCC point is not that easy because it becomes in one plane. So you have to catch that CCC in between the two. Now they come the newer designs. They have some what I can say. There is some difference so that you can put it easily. It's not uniplanar now.
So, Dr. Atul, what is the incision size minimum which we can insert this device?
My incision was 2.6, sir. So it's 2.5 by 2.5. The implant size is.
Okay. And my other concern was what Dr. Deepak said, because we need CTR to give equatorial support along with SC anchor. So that makes more sense to me, because we need to distribute all those forces from the intact zonule to this. So it can, of course, act as give the work of the CTS segment, but we need equatorial support also. So that's a very good device, I think. Yes, Dr. Rohit, want to add, or Dr. Gaurav?
Yes, I wanted to just say something.
Yes, Dr. Luthra.
So, there's a very elegant CTR designed by Boris. I wanted Boris to chip in with his CTR. He has a very elegant CTR, which also has the option to anchor it. I don't know if he showed it today because I joined.
Yeah. First case was that only.
Okay,
Dr.
so
Gaurav.
that
Yes.
I really like that, but except that we can't get it here in India. So maybe if we can get hold of that. And of course, all the other arguments were very much taken, because I think if you need a bigger, wider support, then a CTS will give better support. And if you have a very small space for anchoring it, then I think the SCR segment will be a much better.
Okay. I think, Vardhman, is there any?
Yeah, I think we can go to probably the next case.
Thank you.
Perfect.
Thank you so much, Dr. Atul, for showing this wonderful video. Thank you so much.
Right. So I think we have the next presenter, who is Dr. Sheetal Mawakar Mehta. Sheetal is a cornea, cataract and refractive surgeon based out of Ahmedabad. She is trained at LV Prasad for cornea fellowship, and she has also had her refractive surgery training at Narayan Netralaya. She loves to work with complex cataract surgeries, and ocular surface is her one of the areas of interest. So over to you, Sheetal, for your exciting video.
Am I audible, right?
Yeah, you are.
Yes.
Yeah. Just a second.
So Sheetal's case is the last case for today's show. After that, Dr. Kumar will be showing one of his case. So it's open for discussion by all the panelists.
Is it visible?
Yeah.
Okay. So I'll just give a brief about this patient. So this is a patient who had come to us in November with a trauma with a steel rod.
We can't see your video, Sheetal. We can only see your screen with the folders, with the different films.
Oh,
I don't know if others can see the video.
I can see.
No, we can't see.
Okay,
Can't see that.
I'll just do it. Wait. Is it seen now?
Yeah.
Yes.
Okay. So this is a patient who had come to us in November with a history of trauma 6 days back or something like that, with a steel rod. So it was a blunt trauma. Patient had at that time the vision of just perception of light. Projection of light was inaccurate in 3 quadrants. Patient had a pretty low intraocular pressure, and on B scan there was total vitreous hemorrhage. So this case was taken by our retina department, and he had undergone pars plana vitrectomy along with the PST canapod, that is your triamcinolone or acetinoid. So after that, over a period of time, I think he developed, he regained vision of 624, and recently he came to me with this total cataract. So when I took up this patient for the cataract surgery, obviously I know now there was a trauma involved in this case. There was vitrectomy done. So generally, and there is a total cataract. So I do not have anything to see behind what is there. So I generally discuss my plans with my patients that there could be a change of plan on the table, and I will discuss that if the surgery goes pretty well, and if your bag is stable, we will put the lens inside in the appropriate place. But sometimes we may have to go ahead and put something like a SFIOL. And again, I give them plus minus of anterior vitrectomy pupilloplasty, because many a times they come to me where they're dilated from the retina department and I do not even know. And a lot of trauma cases have realized that sphincters are damaged. So these all things are discussed with the patient. So when I started the case, if you can see it out here inferiorly, there is this red glow which is seen. And this is the superior view. Sorry, this is surgeon's view. So this is the superior side, and the there was a posterior subluxation of whole of the lens. So inferiorly, the lens was little forward, and superiorly, the lens was little backward. So I knew that there was something which was going to happen. So I started my Rexis as we generally do it in mature cataract after staining and all. I started making it a little small, and depending on how it goes, I will increase it with overlapping edge for the size which I require. Now I again take care that the Rexes are, if it is in my hand, because sometimes these Rexes can go out, to make it of moderate size, not very large. So if I need, I can put it in sulcus, my intraocular lens. So as you can see it out here, the initial Rexes which I started was very small. So I decided to increase it a bit by overlapping it. Although this patient did not have too much of phacodonosis while doing it, but these are the cases which are post-vitrectomy. There's no support from the vitreous, so the dynamics are very different. There's a lot of AC which fluctuates during the case. So I knew that there was something wrong.
Can you just pause the video?
Yes.
So a case where, most likely there may be a PCR, it's a white cataract.
Right.
Do you really want to do hydrodissection?
Yeah, so I was aware that there could be a presence of hydrodissection. I many a times do not do it here. I just thought that I'll make it little, because when I started doing Rexis, the Rexis was not like when I put the nick and it tears it. The Rexis, the anterior capsule itself was slightly fibrous. So I actually had to puncture the Rexis to do it. So I thought maybe if the cataract is very adherent, I might find it difficult. So if you see this, I've done multi-quadrant, very, very gentle hydrodissection. But yes, one can avoid it, and this doing even multi-quadrant gentle hydrodissection is a risk, because the nucleus can drop if there is a PCR. So I did multi-quadrant gentle dissection. I did not rotate it because I did not want to do it. And even while doing the cataract, I did not want to rotate the cataract so much. So I was just trying to take the debulk the cataract, and when I tried to rotate it, it was not even rotating it. So I decided that maybe something is wrong, so let's not rotate it and try to just kind of debulk it with the help of the Sinsky and the chopper. And if you can see it from wherever the cataract and the lens is coming out, there is this very clear glow which is seen behind. So once the whole nucleus luckily comes out, nothing goes behind. But if you see, there's a bit of a cortex which has gone down, and there was this huge rent which was there sitting. There's almost no PC behind. So if I'll just pause it out here again and notice this area, you can see the whole PC fluttering because this is the edge of the PC, and this side I don't even see the edge. Again, there is not too much of a problem of vitreous in this case because there's vitrectomy is done. So there's no need to kind of repeat vitrectomy at this point in time. So I went ahead with my cortical removal. Again, as I think as Vanashri mentioned, always in any case, especially in cases where things are a little more complicated, always put viscoelastic material before you remove your irrigating ports. So that is the dictum in general in all the cases, but in such cases, it becomes even more important. So the whole of the cortex comes down. Luckily, the zonules were not bad. So this could be the PCR during the trauma, or it could be actually with the cutter. It's very difficult to say at this point in time, but I think post vitrectomy, before that, he did not have too much of cataract and he developed cataract pretty fast. So it could be during the vitrectomy. I just wanted to see this is a triamcinolone assisted, that sometimes what I have noticed is even post vitrectomy, especially in fakey cases, there is this anterior vitreous which is there and it keeps coming out sometimes or can cause attacks. So I wanted to make sure that there is no anterior vitreous. Also, I thought that by doing a little bit of vitrectomy, if that cortex comes up which has gone down, it would be better, but it did not come, and my little bit of cortex is still down. At this point, there are two options. Either you can call the PR surgeon and take that cortex out, but I thought that it's a very small amount of cataract and it might get absorbed with time along with the steroids. So I put the 3-piece lens in sulcus, and the case was over, went pretty smoothly. This is just a recent case yesterday, so let's see how it fares. Thank you so much.
Can you stop sharing your screen, Sheetal?
Yeah.
Yeah. I think very nicely managed. So now it's open for discussion. Dr. Rohit?
Yeah, I think as always, Dr. Sheetal has really managed it perfectly in a nice manner. Dr. Sheetal, one thing which I would like to ask is, what were the machine settings?
So basically,
Bottle height.
yeah. So basically, sir, most of these cases, I do bottle height pretty low, something around even 50, 60. My aspiration flow rate is very, very low at around 18 also. So it's generally these cases 18 to 20. I hardly go above 20 for my aspiration flow rates.
Absolutely correct. Because, in these cases where you are not sure about the integrity of the posterior capsule, low IOP phaco with low fluidics is a very important factor, so that, even if there's a PCR with the, with the bag inflating, it should not push the nuclear fragments or whatever behind. And as Dr. Harshul has already put in, I would suggest that, if possible, try not to, do hydrodissection, because that, if you cannot see posterior capsule, the dictum has to be that don't hydrodissect.
Yes, absolutely.
So that is, and if you could have done supracapsular as you did, that is also, when you are trying to keep away from the, the posterior capsule. So I think supracapsular, by just pulling out, if you can, I think it was perfectly done. Otherwise, yeah.
Yes, I think in this case, I shouldn't have done hydrodissection because there's no vitreous, and with such a this thing going lens down is just a matter of a second, I guess.
I think low IOP is very important.
Yeah, Dr. Deepak. Yeah.
Yeah, I think it's really miraculous. I find that with such a large PC tear, the nucleus just didn't go down. It's like, it is nothing short of a miracle, actually. Whatever low bottle height, it's a closed chamber technique.
I think
and the moment we go inside, even if we keep it 30, because vitreous is one which actually prevents the nucleus from going down, disappearing suddenly. Now, this is a post-vitrectomized eye. There's no vitreous there, absolutely nothing. So it has a free fall is there. And there is a, maybe Dr. Sheetal has got wonderful hands and a lot of God's grace. It just stayed there and wonderful it is. I can't believe how it could stay there.
No,
Wonderful.
sir, I'm like, I have some theory behind this, not that I have magical hands or, of course, God's grace is always there. But I think it's because of, it was little fibros in the periphery, whatever PC was there. And that's the thing I was saying, that when I touched the anterior capsule was also not immediately, like when we start the rexis, punctured it. I had to put a pressure. So I think that is which has saved me.
I think that's a good point.
And moreover, what I noticed, what Sheetal did was, in one go, she took the entire nucleus,
Absolutely, I was going to say the same thing. Absolutely.
Yeah, so
because
and it was a brittle kind of.
She could not rotate the nucleus because there was already a pre-existing, but the thing was that the entire thing came up in entire bulk. So that is where the game, it changed the game totally.
Yes,
and then you just had the peripheral cortex, and that you could easily manage.
Yes, and I did not actually want to rotate it because I knew there was something wrong behind. Yes.
If there is one clue in such opaque cataracts, one clue to know whether the PC is open or not, I would always like to look at the antechamber depth in the OCT. Now, this is a swollen lens actually. But if usually when the PC is open, usually instead of the antechamber being shallow, it will be much more deeper. So usually we expect somewhere less than 3 mm or 2.5 and such. But if we have a posterior capsule which is open, in spite of an intumescent lens, we find that the AC depth will be 3.5 or more than that. So whenever we have got a larger AC depth in a biometry, that should raise a suspicion that the posterior capsule could be open. Even in a history of where the patient has not undergone vitrectomy, but there is a history of trauma. So looking at a preoperative A-scan ACD is an important clue to assess in a high-risk cases like this.
In fact, sir, this was the case, and this is what something which I was expecting also is if you see it even on the slit lamp, the superior part, which was in our video, was the inferior because I was sitting superiorly. It was much deeper than the inferior part, so I knew that there was at least at that point at that side there was a PC which was compromised. So yes, and that is the reason the SFIL was already discussed with the patient.
How much was the floccular material that went into the cavity, into the vitreous cavity?
Luckily, I have VR surgeon just a call away.
No, that's good, but it's just for the discussion because it was a vitrectomized eye and that floccular material is going to move around in the vitreous cavity. So it's not going to remain entrapped in one position. So I just wanted to know that how much it was like.
That it was a very
one of the techniques that was suggested to avoid the dislocation of the lens in vitrectomized eyes is actually to split irrigation and to place one part of it through the pars plana to equalize the pressure in the posterior segment and in the anterior segment. So you have less chance of pressure gradient and dislocation of the lens. That might be a good idea in that case when you are sure that there is a big rent in the posterior capsule. That might be a useful technique. I frankly speaking, I don't know how many of us are using that, but I think it's a good idea to at least to think about it.
Yes, that's to answer your question, Dr. Priya, there was a very little cortex, but as you said, yes, it is a vitrectomized eye and patient may have a lot of floaters which will go on, and there is a bit of triamcinolone also.
Actually, what happens, in these vitrectomized eyes, whenever we go through the pars plana and do the vitrectomy, that floccular material in itself, it comes into the vitrectomy probe because it's already a vitrectomized eye.
Absolutely.
So it's just floating around and it will, at some point, it will come and get lodged into the vitrectomy probe.
True. So now we'll have to keep a watch on his IOP also because there's a lot of TA which has gone down and it's there. So I don't know how it fares. We may have to take him up to remove that cortex as well as triamcinolone.
Thank you very much. I think that was a wonderful case, Dr. Shtizel. Very nicely managed. And in the last, Dr. Kumar is going to show one of his case, and then we'll finish this session. Dr. Kumar?
Yes.
Yes. So okay.
Can you see the slide?
Yes, we can.
Thank you, Harshul and Vardhaman, for this opportunity. This is a case operated by me only about 15 years back. And this was a bifocal IOL made by Acritech, which was ultimately bought by Zeiss. And the IOL that was a 733, there were two IOLs, 737 and 733. It was near dominant and distant dominant. When the patient came to me, I did not find the IOL in position and there was a YAG opening. There was a sticker of the patient on the paper which was there with him, and patient wanted multifocality. So this is how the patient actually came to me, and the patient was allergic to Tropicacil Plus. So the only way I could go ahead and do anything else was to go ahead and dilate this pupil, and how much it would dilate, you will be surprised. This is all that the pupil really dilates. So you can see that here the pupil dilates only this much. You can see a multifocal IOL sitting down behind the iris, and you can see an opening beautifully done in the center, which was done by YAG. Must have again been done a few years back after the surgery. So this 733 and the 737, which are multifocal IOLs, they never had a square edge then. This is 20 years back. And that's why most of them developed a PCO. So now what was the possibility? Now this patient wants multifocality. Now what can we do? So under topical anesthesia, I decided to proceed with this case. And this is all that you can see as the pupil dilatation is really there. So first thing is to make a side port. You can see that I'm making a little side port here. Once I make the side port, there was obviously vitreous coming out from here. So first I'm going to put epitrate and then see how much the pupil really dilates. So we are putting epitrate inside the eye, and you can see that the pupil slowly dilates. Here the vitreous is coming out. You can see the opening in the YAG, and now you can see the haptic has got dislodged from the optic itself. This is auto dislocation of the optic that really happens. Now this is under topical anesthesia. You can see two haptics, one haptic here, the other haptic here, and the whole disc here. So now I'm going to put, once the pupil dilates, now we decide to go ahead and put triamcinolone, which is diluted. Then to see the vitreous, which is there, of course, go ahead and make sure that it is stained. Once that staining is done, put triamcinolone, Kinacort, which is triamcinolone, put it inside the eye, go ahead and then do vitrectomy. So once the vitrectomy is done, you can see the whole disc rotating around. The incision made is only 2.8, 2.9 millimeters. And the whole disc is roaming around here. You can see that quite well. But now the question is how to remove this. So here I used the micro forceps and the micro scissors to make a cut in this optic, and then use the cut itself. So previously we used to cut the optic through and through till the end and take it out. But now with this technique, I think it's much easier that we make the cut only half. So only one half of the optic is cut. No need to cut all 6 millimeter. And once we cut 3 millimeter of the optic, use the cut itself in the optic as a fulcrum in your incision and dial the lens out. So this is what I'm doing, is now supporting viscoelastic above, viscoelastic below. Then make the use of the microforceps. Very important to take home message would be that make sure that whenever you want to cut anything, make sure that you properly hold the optic. So the grasping of the optic that you can see here with the microforceps is very, 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 very important. If you don't hold it well, you'll not be able to cut it well. So very important that you hold it and then cut it across. Once you cut it across, go across till about 3 millimeter. So half the optic is cut, and then hold one edge which is cut and use the incision itself as a fulcrum. There were some adhesions there which I'm separating between the iridocapsular area, which I'm separating out. And now I'm going to just use the optic and use the incision as a fulcrum and rotate the optic out. Now the question is about what to do about the haptics. One haptic is in the anterior posterior capsular bag. So we are not really bothered about it because it's inert. These are old materials, really nothing to disturb. But one haptic was actually sitting in the sulcus. So I've had a few of these lenses which automatically dislocate over time, but this is just that the whole optic is out. Now taking out the other haptic is also quite easy because it is lying free in the sulcus. But one haptic, as I mentioned, was the other one is lying between the anterior posterior capsule adhesion itself. So this haptic is out. Now the question is, the patient wants multifocality. Now what do we do? So patient always had, and the other eye has got the lens, which is still sitting very well, pretty right in the center. The pupil is fine. Everything is good. So here what I decide to do, this is just breaking the iridocapsular adhesion so that when the pupil comes down, everything is fine. So in such a scenario, of course, you do your calculations, and then I go ahead and decide to put a Technis multifocal IOL in the area. Just make sure that there's no vitreous sitting there. Go ahead and do a little bit of vitrectomy and make sure that everything is completely free. And then again, put the viscoelastic. Then I go ahead and take a Technis 3-piece multifocal IOL. And then we try to inject this into the sulcus, which is ideally what we really want to. And I'm quite used to using these IOLs because we've been doing this for many, many, many years. Just very easy to use. This goes beautifully in the sulcus. But the question is, we cannot afford this multifocal IOL to decenter. So how are we going to make sure that it centers beautifully in the center and never ever decenters? And believe you me, I've done this surgery a few months or a few years back again, or maybe 1 or 2 years back. The lens is sitting beautifully in the center, and I'll show you why. Now, putting the lens into the sulcus is quite easy. Just make sure that the IOL unfolds, and then we release the IOL in the sulcus. Once the IOL is released in the sulcus, my goal will be to make sure that we can do an optic capture into that capture. Actually, it's a YAG opening which is done there into that YAG opening. So make sure that we can do an optic capture, right? So now the one sulcus is gone, one haptic is gone into the sulcus. Now I'm going to dial the other haptic into the sulcus, make it horizontal. Once that is done, we have an opening, which is actually the YAG opening, which is done. And now I'm going to slide the optic inside one edge and then the other edge. So you can see that I'm bringing the optic edge there and then sliding it below. And then you can see that that is become straight. And now the superior edge, and this 3-piece multifocal IOL will never ever decenter. There's no vitreous there because we've done the vitrectomy, and this will do extremely well. So this is what I did for this patient, and then go ahead and make sure that it's very well centered, which obviously it would be because that's where the YAG opening was. Made sure that there's nothing lying in the anterior chamber, and completed removal of the viscoelastic and the from the anterior chamber and removed this, and then went ahead and did this. So that's only one case I wanted to show.
Yeah,
thank you for your opportunity.
It was amazing. A lot of I think take-home messages including the way you had handled the IOL extraction also, like a Pac-Man, to cut it in 50% and then remove it. And what I wanted to know was, what was the biometry that you have chosen when you do the posterior?
Yeah. So as I said in my talk, that the sticker of the original lens was there on the patient's paper, and it was almost 16 years back. So we are now putting it posterior. So we may take half a diopter more than what it was original, because now it's going behind the posterior capsule. It's not anterior, although we are placing it there, but it's going behind. So that's the only additional care that you have to take. And with a 3-piece multifocal, it's quite easy to do that.
Yeah, I think the use of 3-piece multifocal was also quite intelligent actually in this case. And it is one of the, I think probably the only 3-piece multifocal lenses we have currently available, and works well. We have had like few cases, but I think this was managed beautifully. Could not have been better, of course. A lot of things to learn. Great. I think Sheetal
Yeah. So I have two questions, Dr. Kumar. One is because you were going to do the optic capture. I don't know whether that was planned before you took the surgery or that was at the moment you planned it. But say if before, right? So did you make any change in your IOL power calculation, like?
That's what I said, that the sticker of the original IOL was there with the patient.
But that was the sticker, that was the IOL which was put in the bag, right?
Correct. So you add 0.5 more to that. And that is what I put with the A constant of the IOL of the Technis multifocal at 0.5, because you are going behind the bag.
Yes. So you did that.
Yeah.
Okay. Other question what I wanted to ask is, what if you did not have sticker? How would you go ahead with it?
Then this was tough, because then you have to do a phakic mode calculation, because when the pupil was small, that lens was still in the area of the pupil. Then you have to do a phakic mode calculation and hope that that calculation works fine, and then do the same way the further calculation. So that's the only way you can.
You mean pseudo phakic mode?
Yeah, pseudo phakic mode.
Yeah.
Even if you are small, still okay. Yeah.
Thank you so much, Dr. Kumar, for this wonderful case. And I'll request our panelists to please keep your cases ready for the next symposia. We want you to show some of the challenging cases like this to everybody. And Vardman, I think we can end the session now. Yeah.
Absolutely. Yes.
Thank you, both of you.
This has been amazing. I think a lot of learning tips, and we have seen a lot of new innovations. We have seen probably Professor Malugini's ring for the first time, the new CTR ring. We saw the SE anchor. We saw amazing cases of subluxations of toric IOLs. I think it has been amazing potpourri of different complex scenarios. We are very, very thankful to all the presenters. Sheetal, Dr. Kadane, all the way from Bangladesh, Dr. Prakash, Dr. from Russia, I think fellow of Dr. Boris, Dr. Eric?
Dr. Ivan.
And so I think it has been amazing, and to have all amazing panelists from all across India, and also Professor Boris Malugin coming all the way from Russia has been great learning experience for all our viewers, and of course for presentations to all the speakers as well.
Once again, thanks to all our panelists, Dr. Malugin, Dr. Rohit Om Prakash, Dr. Gaurav Luthra, Dr. Kumar, Dr. Jagat Ram sir, Dr. Priya, Dr. Shikha, and Dr. Namrata couldn't join, but we have more panelists who will be joining in the next sessions. Thanks to all the presenters for making this session wonderful. Thank you so much.
Thank you. Good night.
And
Thank you. Wonderful
and three cheers for all the tough guys and girls.
Congratulations.
Okay. Bye-bye. Take care.
Bye-bye. Take care. Bye.
Bye-bye. Bye.
Hi, Dr. Rohit. Good night.
Hi, good night. Yeah.
Dr. Harshul, good night.
Bye-bye. Thanks a lot, Dr. Prakash.
Dr. Vardhan, thank you so much.